cameras on. And to all those who are staying by their cameras, we're happy to see you. We're happy that you've got connection, electricity, internet. We're happy that you are here. So we are absolutely happy. We try to be happy about anything possible. So thank you for staying with us. I'm Anastasia Leuchina. If somebody doesn't yet know me, if some new participants have joined me, let me introduce myself. I'm the author of the Not So Scary book, Blood, Life, Death, and Everything in Between, and the editor of the manual entitled Humanity and Empathy in Healthcare. And by the way, Larissa is showing this Not So Scary book. Thank you. So, in fact, now we are launching the session of the Laboratory of Empathy in Healthcare. This is a series of broadcasts, events, discussions which in fact has been developed for the sake of investigating into the best practices, sharing best practices in teaching medical communication and empathy in medical education and in healthcare. We have several co-authors of this manual here among us. You've just seen this manual, and the QR code for downloading this manual could also be sent out to you. But actually, we have devised this series of events to share experience. And you know that we have had some broadcasts both with Ukrainian and foreign experts. So I'm very happy that today we're going to speak about rehabilitation, which is an urgent need for all of us now, which needs to be developed very quickly. You know why better than I do, because there is a great need, a great demand for that. So I have invited for this broadcast with great inquisitiveness my colleagues, Laura Verweijen from um, the Netherlands and Anna Dvartir from Hungary, for us to talk about the communicative component in teaching rehabilitation experts and about the importance of this component in rehabilitation as compared to all the other specialties. I got acquainted with Lodo and Anna in the context of my work and my membership in the International Association for Medical Communication, Healthcare Communication. Each we are in one group, Teach. This is a special group for teachers, of lecturers, and they have kindly agreed to share the experience today with us. Both Loda and Anna are practical physical therapists, and they've also got the experience of teaching, lecturing. That's why today we will get the experience both from this point of view of theoreticians and from the point of view of practitioners. Let me tell you a couple of words about our speakers. So Anna is a physical therapist, a practicing one. She also used to teach at the University of Samgways, and she also conducts research into communication between patients and doctors. She works in Budapest, while Lola is the head of the physiotherapy clinic in Antwerp. And there is some interesting information about Loda saying that he works a lot with athletes and professional swimmers from Belgium, well, also with the Royal Ballet of Flandria, the Symphonic Orchestra of Antwerp, and he also teaches medical communication at the university. So you can see that this is really broad and diverse expertise. So I hope that Loda and Anna will tell us a little bit more. I was hesitating about the form of the Ukrainian word to be used here about the experience. They will do it during the presentation. So we will hear from them. There will be some quick presentations, and after that, we may well have some Q&A session, and we will ask you to write your questions in the chat the moment you get any questions, and we will try to cover them in our space whenever there is a minute to spare for that. So now over to Anna. Anna, let us speak about inquisitiveness and curiosity.
Okay. Thank you very much, Anastasia, and welcome everyone. I'm honored to be here. And I read through the amazing amount of questions and comments that you had to fill before this webinar. And what what really impressed me that, well, obviously you have a very difficult situation now in Ukraine, and I can't even begin to imagine, to be honest. And even though the impression I got from the questions and the comments is that you are also motivated and inspired and want to do good and really get the gist of this human healthcare and want to improve this in your country, the same as I'd like to do it in Hungary. So kudos for everyone. And in this war context, I think it's even a bigger achievement. So I'd like to say a few words about how we structured this webinar with Lode. So I start now with some introducing myself and telling a bit of a background of my personal background, and then some general ideas about person-centered care, which I'm sure you've already heard a lot about. So just some main points, and then Lode will take over to connect to the relationship building and empathy part of the human connection. And the main division of labor is that I talk more about the practical executability of this person-centered care, while Lode will talk more about how to teach these. So if you have any parts that you feel is missing while I'll talk, I'm sure you will get the answers from Lode, or you can ask the questions which Sia will will transfer to us. So I think we can start with the first slide. And this is my first time ever that I'm doing a webinar where while there is interpreting and that I don't understand the slides. So apologies if I make any mistakes or
We
I'm not
we will
very
don't worry.
simultaneous
We
with.
will correct it. It's okay.
Yeah,
We will figure it out.
shout loud. Yeah, okay. So the title we came up together with Sia and Lode is the Curiosity and Communication in Rehabilitation Training Programs, the why, the what, and the how. And I think the subtitle is maybe even more important, to be curious and find the truth in each patient. And,
Somebody just unmuted by
and
accident.
so yes, thank you. So my full name is Anna Udvardi, and I have two degrees actually. My first degree is in general linguistics, and I'll tell you in a minute why this is an interesting part of my life. The second degree is the physical therapy. So you can skip to the next slide. And I did a PhD in physiotherapist patient communication. And I was researching the opening questions of physiotherapists, so how they pose the question of about the problem, why the patient is there, and what kind of answers the patients give. And this was a very important experience for me research-wise. That it supported my personal experience. That sometimes we feel that patients are not always answering the question that was asked, but surely for some reason they tell their story in their own way, so they answer in a way that is important for them, and this was shown by the research too. So an important factor is that here in Hungary physiotherapists don't learn about healthcare communication at all. I don't think the situation changed since I graduated 15 or 16 years ago. So I absolutely discovered the importance of this in a postgraduate course. So this is where the linguistic background comes in, because one would think that if I'm a linguist, I am immediately aware of the fact that communication is important. But since the school was absolutely not about that, only diagnostics and the biomedical stuff, I really didn't realize. And then I went to a Mackenzie course. That's a method within physiotherapy. I'm working with this method in Hungary. It's for musculoskeletal problems. And there the instructor had a beautiful way of speaking with patients, because there during the courses the instructors see real patients. And there I was starting to realize that, oh my God, these questions he asked, how did he get to convince the patient to do what they didn't want to do at the beginning? So this was the first point where I started to get intrigued by this topic, and this led to me choosing healthcare communication as my PhD research, and then basically finding each. So the International Association for Communication in Healthcare gave me a really good framework also with their courses. I visited several of their courses, and the community to share this passion, basically. So in Hungary, I had less help regarding experts and how to learn or teach all these things. I think we can go to the next slide. So we're jumping immediately to the topic of person-centered care. And as I mentioned, I'm sure you all know well, maybe not everything, but the main points. That was obvious from your questions and comments too. And we think with Lode, and not just us too, but I think many would agree that curiosity is the main factor or the key here in person-centered care. So unless you want to know the patient as a human being with their own context and or own difficulties and values, you can't really provide an individualized care. You have to understand what they prefer, what their values are, what the challenges are in their life, what challenges their problem sets in their life, and only this way you can be empathic and respond in a way that is meaningful and relevant to the patient. And there was an international working group. Next slide, please. This work started in Glasgow. Surprise, surprise! It's called Glasgow Consensus Statement. That Gregory McCool initiated an international workshop where the goal was that we kind of agree on some cornerstones of healthcare communication. And the difference between previous consensus statements is that on the one hand, it is not only meant to be relevant for doctor-patient communication, but we wanted to tell something that can be achieved in all healthcare contexts. So doctors, nurses, physiotherapists, dietitians, whatever allied health professionals there are. And considering the fact that as healthcare becomes more and more fragmented and there are a lot of technical advances, but at the same time, a patient may see several health professionals, maybe not even the same doctor is caring for them all along the way. But even in the short encounters, we must provide a human care. So this was the goal, that an effective communication is well developed. We already know the main points and factors, but some easy to remember and easy to build upon principles are determined and agreed upon. So one of the things is that next to being curious, we have to build a trustworthy, trusting relationship with the patient, that they feel safe, and an effective communication in a way that we both understand each other. So basically, there is a mutual understanding and not just assumptions, what I think the patient wants or what the patient thinks, why I'm asking a certain question. So the working group came up with 3 overarching tasks, and that's on the next slide. And these are, so these 3 overarching tasks are: connect as humans, focus on understanding. Originally, it was called understand the patient's perspective, but then that was generalized to focus on understanding and to be responsive. Of course, these are not separate phases of the healthcare encounter. This is interwoven all along the way. So, of course, it's not only important to connect as humans at the very beginning when we see the patient at the first time, but all along the way. So, connecting as humans means that you have to treat each person as a unique human being with their own context, and to convey attention and respect, both verbally and non-verbally. The second point, again, emphasize that these are not separate phases of the visit or encounter, that we have to understand each other basically, but in order for the healthcare professional to be able to provide meaningful care, we have to understand the patient's view on the matters that are related to their health and healing, their illness experience, and we have to incorporate this knowledge when shaping the care plan and when providing patient education. And this is already connected to the third task of being responsive. So, based on the understanding we gained during the encounter, on the one hand, we have to tailor our communication, both form and content, to the patient who is sitting or standing in front of us and to their problem and unique personality. And obviously, we have to react on emotions as well, which I'm sure you know a lot about these days. So connect as humans is the first overarching task, and I'd like to say a bit more. The next slide, please, about this part. So obviously this starts when you meet the patient, you introduce yourself, you state your role, ask about their name, how you may call them, provide comfortable seating or position, and respect the patient. So these are the general ideas, and how we can do this maybe specifically within the physiotherapy and rehabilitation process. And what I'm talking about is mainly about musculoskeletal problems. This may be an important factor. So when you ask about the work of the patient or their leisure activities, you can immediately gain an impression of their personality. On the one hand, this is a nice moment to connect. Even if you don't know their work or their leisure, you can spend a few sentences or half a minute to inquire. Then they already feel that you are interested in them and you pay attention. But also it is clinically important. So if you have any musculoskeletal pain, the load that you are prone to during your work or during your leisure activities may be a factor in the problem, or it may be a factor that the problem persists, but it can also be a goal if there are functional limitations. So if the patient cannot continue their work or their leisure activities, this immediately provides an opportunity to start, not negotiating, but exploring the goals of the patient. And at the same time, if there are several severe functional limitations and you realize the difficulty of the patient, it provides you a moment to express empathy there. So the main point here is that we learned about the patient, the unique trait of that individual, and this is important for the connection part, so building relationship, but also it has clinical relevance as well. And here I'd like to pass on to Lode, who will talk a bit more about this relationship building and empathy.
Before you do that, can I just really quickly ask you one question?
Sorry.
Because I assume that because of our common history in a way and similarities in educational system, we have a similar problem. So, well, in the registration, some participants kind of asked how to move students from their understanding of biomedical repairing of the body mindset to a biopsychological and supporting the person that you are talking about. Maybe you have some examples of how it happens in Hungary. I mean, Loda, you are also welcome to join, but in Ukraine, it's very common that that patient is viewed as an object for repairs rather than as a human, and it kind of contrasts with what you were talking about.
I
Саша, ты
think
не знаешь, где тут мне включить, чтоб...
Can I talk?
Yes,
Oh,
sorry,
sorry.
I just muted someone.
So I think it's a nice experience to face them. How do you call it? So anyway, if you give them a task that they think about one of their own healthcare problems from or the latest one, and start to talk about it. And let's see what they talk about. Do they only mention the physical problem, the pain, or do they mention that, oh my God, I'm not able to do my sport, I'm not able to play with my friend or go hiking? And there comes immediately the context and the values of the patient. So I think if you have a kind of a role play like this, or it's not even role play, actually, it's an imitation of a real situation, that they can start to realize that it's very rare in my experience that patients really come with the medical problem itself. That's my,
So
and Loda
basically,
maybe contribute.
you are suggesting to use students' personal stories to kind of engage them in the conversation and bring their human part to the conversation, not just the professional identity.
Yeah, I think, yeah.
Thank you. Lode, the floor is yours.
Yeah, your question was a nice one because that's exactly what I'm going to talk about, how to make this change in mindset of the students, but also from other professionals working in rehabilitation. My name is Lode Verrijen. It has been said that I was from the Netherlands, but that's not true. I'm from Belgium, Antwerp, Belgium. But no offense. Can I get the next slide, please? Because I will be talking about how to teach and learn relationship building. Anna already has mentioned these things. This matters because communication is a clinical skill. Communication is not something you do or you don't alongside your work. Communication is one of the main clinical skills we need. And we need to establish a therapeutic relationship because that influences recovery. There's been lots of scientific research done. If there's, for instance, no trust in the healthcare provider who's treating you, even how good he or she works, it won't work for you, for that particular patient. So the relationship we have is very important. And students, as well as colleagues, sometimes they need concrete and practical tools. Can I get the next slide? That's my bio. The next one is the one I was talking about. If I can get it, the next one. So that was what I was talking about. And it's all about safety, especially in your country, I can imagine. And what about trust? People need to trust us. If you don't trust a person, look in your personal life, things don't work, not communication, not having a relationship and whatever. And it takes some time to build this trust. And what we learn, our students, be careful with this trust because you can destroy it in seconds. So be careful with that. So what about trust? The next slide, please. We have to create trust and we have to create an atmosphere of safety and acknowledgement. Safety that so the person in front of us feels safe enough that he or she can express whatever he or she wants, that there are no restrictions. And as you well know, all know, the first impressions, they set a tone. So when we teach students, we do an exercise on these first impressions. I've put this picture on this slide because it shows a very nice and comfortable atmosphere. All the time, you can't there's nothing, how do you say that? You cannot communicate. You cannot not communicate. There's always communication. Even if you don't say anything, you still communicate. Non-verbal communication is, in that matter, also very important. Can we go to the next slide? And there are some core principles in this, having this open body language, having a warm, supportive language, so not only verbal, but also non-verbal language, validate emotions, and, as they say in English, chunk and check, so summarize and check all the time if you understood the person in front of you, and or if the person in front of you understood yourself as a caretaker. Next slide, please. And for people who have been asking some practical exercises, the next slide is giving such a practical exercise. It only takes 60 seconds, and this relates also to the question that Anastasia just posed to us. What about students who are trained in this strict biomedical way of looking to people and not the biopsychosocial way we want them to do so? So what we are asking is, one of the students is talking about an issue, a practical issue that happened to that student with his body. How do you say? I'm mixing all the time French and Dutch and English. And so it's coming from their own life, and the other student has to try to do that in the most comfortable way, so that the student patient who's playing the patient can get 60 seconds to tell his story and to feel hurt and to feel the empathy of the other student playing the role. And then after 60 seconds, we switch and we teach them to show genuine interest, to listen actively listening, and use simple, clear language. No, not too much talking. On the contrary, we teach them to stay quiet and to just listen. There's a huge, one of the largest radios, Radio 1 in Belgium, and they've got their motto. They always start Radio 1. It all starts with listening. So when I start my class, I use that motto from Radio 1 in Belgium. It all starts with listening. And try to make them ask simple questions as, how is this for you? How do you feel about it? Etc. So that's a very practical 60-second exercise, and you can start discussing later on. And that's what Anna just told us, how we can use the personal life of the student to get them into this mind switch. Next slide, please.
Lode, sorry, just a technical question. So a
Ой,
student
блин, ой, блин, ой, блин, ой, блин, ой, блин.
So a student gets 60 seconds on air to open a meeting, and how much time do you spend to discuss how he did it or she did it, like the debriefing part?
That depends a bit on how what their reactions are, but most of the time we give them some time, because it's no use. And with some time, I mean like 5 minutes for that exercise, and then we switch roles, and then again we do it, because then we hope they learned something about, they take already something about the first exercise, and then they switch roles and they do it again, and then we give them, for instance, again 5 minutes. This is also relating to the work we do. We give time to our patients in front of us before we start treating. So that's why we give them time to do the exercise, 60 seconds, but we give them also time to discuss and to put their questions and asking for answers. Is that an answer to your question?
Yes, and the reason I kind of wanted to go deeper into this because I observed that we as teachers and also doctors. I'm not a doctor, but I think in general we have a tendency to rush, like because the time is so limited and there is this always pressing rush in the background that makes it like increases stress and makes it difficult to interact. And the second question, I mean, the second issue is that oftentimes I'm noticing that when people teach also soft skills or communication skills, often time is allocated for demonstration or role play, but it's never enough time for debriefing, for learning from it. And also when we had a conversation with students, they said that oftentimes they just don't get the feedback. So they do something, but they don't know whether this was a good thing or not. They get a low grade, but they don't know why. So that's why for me, it's really important to emphasize also, and thank you for doing that, that we need to have like 5 times more time for debriefing and learning, for example, than the demonstration itself.
Why we make a small exercise, just 60 seconds, we time it, but that's why we give minutes afterwards so we can discuss. So they are really getting the proper feedback. The next slide, as you can see, there are two, and that's already showing what Anna was talking about. Two people with back pain who can have a completely different, can relate completely different to this back pain. This back pain can mean a completely different thing. The one who can't do his sports, who is training for a marathon, his or her first marathon, and sees all the good work disappear because of this back pain, and the other person might struggling with the back pain and not being able to work again in a firm that is undergoing a very stressful period. So it's not the time to be absent and to be at home with back pain. So that person really wants to continue working, but can't, etc. So you see, we are treating people with back pain, and we are not treating just back pain. The main reason why we do that is you get better adherence and better motivations. Better adherence means that people, when we give exercises, when we give corrections in their daily life, they are going to adhere better, they are going to change that. There's more chance they will be changing that. So that's why we do it. And this nice metaphor I really like, this the iceberg. When people come in, they start with the surface. What's above the surface? That's general. I have back pain, they tell. And then it's for us and students, and that's what we teach them, to get below the water and see the bigger part of the iceberg below the water, to see if we can, in a gentle, constructive way, to dig that up. What's behind this first sentence, I'm having back pain. So I like the metaphor of the iceberg. So we go to the next slide, and then we teach very practical questions. And that is what students mostly ask. How should I ask that? And we give them small, we ask them themselves to bring up some open questions, and so they can learn from each other. And I always tell them there are no bad questions. There will be more closed, more open, but at the same time, when they start working, we immediately give feedback. So they learn to make person-centered questions and to see these two perspectives. Again, to the question of Anastasia, the biomedical, of course, is important, but they should first go to the human factor, the story, the impact, the emotions behind it, and discuss the difference. And we also give them reflection tasks like, what did you learn today by the end of the class? What did you learn today about looking through a broader lens. When you go on as a trainee to the hospital tomorrow and you get your first patient, what are you going to take away from this class and present to the first patient you will see at the hospital tomorrow? Next slide, please.
Sorry, before you move to the next one, there are two questions in the chat. One is from Tatiana, whether you use simulated patients in your classroom, and another one from another Tatiana. I assume she is referring to the slide with the checklist for students. Do you have some specific points or phrases that they have to use, or how do you evaluate that they did a good job?
Yep. I'm going to answer the first one. Yes, we use simulating patients. So at the university, I was the trainer of the simulating patients. And that's very useful. Students really like that. It makes them feel scared, scared in the beginning. But our simulating patients, together with us as teachers, we provide a safe atmosphere for the students. So that's the first thing we do, exactly as you would do with your patient. So they get into it. And we always tell them, for instance, don't worry, your communication will be good. It can only be fine-tuned. And that's why we are here together with this simulating patient. So that's how we use them. But the students like it. And the second answer, no, we don't use a set of, we give some examples, but as I said before, I make them think themselves to come up with open and patient-centered questions. And we can still discuss them, like somebody is giving an example, which is not too bad, but can be better. And then we start, then I ask my students, this is a good one, this is already a good one, and how can you make it even better? So everybody needs to think that's a good start. I'm going to use the same sentence, but I'm going to change this. I'm going to twitch it a bit. I'm going to change it a bit and to make it better. We don't use a particular set because in different parts of Belgium, or the students I have, we have a lot of dialects. I can imagine in your country as well. So the way I address my patient in Antwerp will be completely different than somebody who does that in Brussels or in Ghent or any other part in Belgium. So it's no use to give them a strict set of questions. I hope this is answering a bit your remark. Yeah. Okay. So the third topic is about curiosity. Anna was always talking about be curious in a genuine way. Don't act, because if you start acting, patients all immediately recognize that. And also students. When a student is acting to be curious, most of the time all the others starts to laugh, because non-verbal communication, that doesn't lie. So if it's not genuine, it doesn't work. And why does it work? Curiosity, or Annie already told you, it improves clinical reasoning, it reduces assumptions. We don't assume that a patient is having whatever kind of problem. We need to know, we need to ask. And it strengthens the collaboration to start working and for the patient to do his homework. And again, the open questions are a driver to get this curiosity. Like, tell me more about how do you notice that? How does this make you feel? And what makes it difficult for you and stuff like that. So we go to the next slide, and this is also an exercise. We make students ask until they understand, and they do it by most of the time by trios. So there's one observer, and this observer is noting how the question, what are open questions, the depth of the questions. Think of the iceberg. Is there space for emotions? Did the student playing the physical therapist, is he making assumptions? And so we give this we talk when we talk afterwards, the feedback, we have this experience circle with 4 dimensions. What is the physical part? What is the functional part? And in that one, they are really good because they are trained constantly in this physical and functional part. But then we add the social part and the emotions. The next slide, and I'll come to my conclusion. When I can summarize, this relationship building is a foundation. So to see the person and not the diagnosis, and be genuinely curious, because that's the key to understanding. So, as I said, communication is not an extra skill in healthcare, it is healthcare. And there's another nice English expression. We should be, and to make this change of attitude, as well as for students and your colleagues, especially when you're working in an interdisciplinary setting, is not asking what's the matter with you, but asking what matters to you. It's a very simple English phrase, but exactly shows the attitude we should have in healthcare and in communicating in healthcare. Change what's the matter with you into what matters to you. So I think it's time for Anna again.
Unless Anastasia wants to ask something, or the participants.
I can
Yep.
throw in a question. This issue comes up quite often. On the one hand, we speak about empathy and communication as a skill that can be trained. On the other hand, people may feel the artificial kind of taste to what is being said because it's like a trained skill, but it's not real empathy. And I think Loda also kind of mentioned it in a way about nonverbal and honesty. So the question is, how do we, or maybe you can comment, how do we train people to be naturally and genuinely curious as opposed to formally communicating? Do you know what I mean?
Yeah, I understand, and I already mentioned when a student is putting a question to the one who is playing patient, or when there's a simulating patient. Our simulating patients, for instance, they immediately detect the fact that the student playing like physiotherapist or doctor is not genuine curious, is like acting empathy. And our simulating patients, they react on that as a normal patient would, like a bit surprised and confronting the student with his acting. And most of the time, the colleagues, students around it, they start laughing, as I said. And that's a moment where we try to change that attitude from acting to being genuine. And I can add to that, we try to work at the university in rather small groups. I know that's very difficult, but we manage in our university to work in small groups. And when I say small groups, it's like between 10 and 20 students. So it's quite easy to involve quite a lot of them, perhaps not all of them, but quite a lot of them, and to get a lot of feedback to them.
Thank you. Anna, would you like to add something? Because there is another question in the chat.
No, I think Loda answered it properly.
And the next question is somehow related to this one. And it sounds like how to find the balance between a natural empathic curiosity and also own feelings about patients suffering that are genuine. And how do you maybe draw the line between, yeah, between worrying about the patient or being sympathetic about the patients and actually the genuine curiosity that helps you move the conversation.
So the genuine feelings of the therapist to
Yes.
draw a line between the empathy and being really too much involved in their
Yes,
lives.
and how it can be trained.
Yeah, I think here Orit's webinar comes in very handy, where she emphasized reflexivity, the self-reflection part. So basically, when we we have this interaction with the patient, we also continuously have to be aware of our own attitudes and feelings and beliefs and preferences. So maybe it's easier to draw a line if you, on the one hand, realize that now it's me worrying about the patient and not just being empathetic, and that if I'm too much involved, I cannot satisfy my role to be able to help in case it can be helped, the situation. So in order to fulfill my professional role, the being too much involved, feeling emotional wise, would be a barrier to that task. But first you have to realize what you are doing there.
And maybe
add to that.
Mhm.
Sorry, go
Yeah,
on.
please, Lode.
Yeah, what I would add to that and communicate that with the patient. When the patient is telling me something that I really can't relate to, which is so severe, like the questions we saw passing, people losing a limb, for instance, soldiers coming back from the war. These are things that are beyond my possibility of imagining what was happening to that person. Then I can again communicate that. What you are telling me is for me very difficult to understand. I really feel empathy with you, but this is too far away from it. So you have to explain, for instance, something like that. So you can communicate the fact that what a patient is telling sometimes is really far away from my own life. Because apart from the self, or this is the follow-up of this self-reflection that we sometimes even have to communicate that.
Thank you. And maybe here, I don't know, or maybe later, but I will just put it here. And I know that there are more, you have prepared more slides, but maybe you could elaborate a bit more how to discuss these sensitive issues that are beyond therapists' understanding or experiences. I mean, of course, we received a lot of questions about the war context, and how to go into these conversations, also in a sensitive way, but also respecting that they can be traumatizing for these people. And maybe you would like to share something now or later.
What I tend to do is I'm going to give you a practical example. I once had a young woman who suffered, and she only told me after the fourth or the fifth treatment, at the moment that she really felt comfortable and really felt safe because of my kind of communication with her and the way I was treating her. She had been suffering a child abuse. If I would be saying at that point, after having heard her story, and if I would have said, I understand, that would sound a bit like acting. What I did at that time, what I said to the patient, what you are telling me now, I completely don't understand. This is something so far away from my own life that this must be so tough for you that I even can't imagine how tough it has been. See the difference? And that's about being genuine. And the simple fact that I told her that I even couldn't imagine what she has gone through, That's genuine. And then that's what she really understood.
So just going back to this, you basically wait for people to bring up the issues related to their traumatic experience themselves, and you give them space to decide how they do it. And at the same time, you yourself basically reflect honestly what you are feeling or thinking without trying just to be polite, right?
Exactly. When you really have, you can't dig up everything. The lowest part of the iceberg, you have to provide safety and time. Time is our best friend. And when we provide that, sometimes after a few treatments, when the patient really finds the time and the safety, start talking, like for instance in your country, post-traumatic stress disorder, only then you can address it. But it has to come from the patient. We shouldn't be digging just to start digging for things that perhaps not there. So the most important things will come up. And if there's something really below that needs to come up, it's for the patient to decide that. The patient will feel that we are giving a safe environment and the proper communication.
Thank you. Anna, do
Shall
you
I
go
jump in?
next? Mhm.
Yeah, sure. Thank you. So then I'd like to have the next slide, please. And as Lotte talked, I think it very nicely was described how all these tasks are interconnected. So basically, how we build a relationship and apply, this is the bad word, but we are curious and learn about the patient. Basically, that immediately channels into understanding, because as you get your answers, your impressions, as you watch the patient's body language, silences, ask explicit questions, not just assume, you get to know them better and understand them better. So basically, the second overarching task is this focus on understanding. And here I'd like to divide this part into two main components. One is about the patient's goals and expectations that I think you should explicitly ask at some point of the interaction. And the other thing is that you realize and maybe explore more about the so-called drivers of pain and disability. These are cognitive or emotional factors, or maybe contextuals too, that may influence the recovery. So the outcome, or they may create a burden, or not burden, sorry, a barrier to a successful recovery. And only if you understand this fully, so the patient, the context, their illness experience, their fears, their beliefs, their goals, expectations, only then you can be responsive, which is the third task. So the next slide is about, from my own assessment forms, I collected only some of the goals and expectations. And what is interesting, so I usually ask at some point that, like this, what are your goals? What do you expect to achieve with our mutual work here? What do you expect from the therapy or something like that? And some patients are surprised. I mean, what do you mean what? Of course, to get rid of the pain. But on the other hand, it's so diverse how they express themselves. So what you see in these bubbles, to become more active or to get answers, surely to decrease the pain, get their life back, the quality of their life, understand what the problem is, what can I do, how can I treat it. So it's really not just about the pain. And the one I put there, the heal me, is an interesting one, because how they express themselves in this case with the goals and expectations, you can also get an impression only, of course, how responsible they feel in their own problem, what their locus of control is. So do they expect you to fix them? and they are being a passive player in the game, or like the what can I do to self-manage, then you I think have a better starting point there. But you have to realize this as well. So it's not just about the pain. And if we continue to the next slide, that's about some examples of this second component, the drivers of pain and disability. So these can be like fear avoidance behaviors. In case of low back pain, this is regularly that they don't dare to bend forward, so they completely avoid the movement, or they really fear about the pain because they think if there is pain, then surely there is harm in the structure, or they are in a depressed mood, or they think that surely this problem will persist and there is no hope. So these are the beliefs and attitudes that can create a barrier to healing. And even there is evidence that this can lead to chronic pain. So from acute pain, these attitudes can lead you to chronic pain. So again, it's not only important to be human and connect and understand, because healthcare is about humans, but also this factor again has clinical importance and relevance and consequences as well. So if we explored all these factors, then we can fulfill, or we have a chance to fulfill the third task of being responsive, which is the next slide. And here, it's on the one hand, it's about the tailoring the communication. So what we learned about the patient, that's how we plan the treatment, that's how we educate the patient, that's how we provide information. What we learned is important and relevant for them as individuals. And obviously, we have to react on the emotions as well. Here again, my advice and my experience is that explicitity is the best thing. So if we ask, so I had experiences that the patient comes in and I immediately see that something is not good. And I start to worry about the treatment. So, oh my God, everything went wrong. I'm sure they are worse. I'm sure the treatment didn't work. And then I ask, okay, I see, or I have the impression that you're feeling a bit down. Is that correct? Why is that? And on the one hand, I had the experience that they are surprised that I immediately noticed their change in demeanor. I don't know how to pronounce that. And it can turn out that it has nothing to do with the physiotherapy. Oh, yeah, I feel a bit down, but it's because, I don't know, I was late from work today, or my cat died, or so physiotherapy or the healthcare encounter is just a small part of their lives, actually. So not everything is about that treatment process or the therapy session. But it can also turn out that yes, they are disappointed because it didn't work as they expected, the therapeutic process or strategy. But then we can discuss that too. So instead of assuming things and start to kind of have a snowball of bad feelings from therapist to patient and backwards, we can clarify and talk about it. Or maybe just one sentence that, okay, it's nothing about this, we can move on. Yeah, and here we have a few scenarios, but I don't know how much time we have. We don't
We
have
are
to go
good.
through
We are
all.
good. Yeah, we can.
We're good. Okay. So I came up with a few examples. Lode already mentioned. Everything is about low back pain. And the first scenario is basically maybe the simplest or the most obvious. Again, the scenarios can have overlaps or how do you call it? So more components can be in one scenario, not separate, like I present them. But scenarios one is that the patient has low back pain and they just want to get rid of the pain, abolish or decrease. You did the history, physical, you found the movement that decreases their pain. So the main task is that you provide what they have to do, how many repetitions, so the home exercise program, what reactions are acceptable, non-acceptable. On the other hand, if we consider the second scenario, again, low back pain, where where it turns out during the history taking that the patient's main goal is to avoid surgery, or they have fear that they would need surgery. And let's say that you question them, examine them, and there are no clinical signs or symptoms that would indicate surgery. Then if you think back that first scenario, it's not enough to just tell them, look, we found this movement, this decreases your pain, go home and do this exercise, because that won't answer these concerns of theirs. So there you have to explain what you found. You may inform them about the indications for surgery in case of low back pain. And many times, in this case, I don't even have to say as a therapist that surgery is not indicated based on the information they concluded themselves that, oh, okay, then I don't need surgery. So let me know if it's not clear, but this is how I try to demonstrate. And there's another scenario again. These are also from the bubbles, if you remember. So the third one is that the patient just wants to understand what their problem is, what the underlying cause of the problem is. Again, here you may highlight the findings from the history taking, how the problem behaved, that they told you what their experience is, how that relates to the physical examination. And based on that, you can tell them it looks like either a disc problem or a narrowing of the spinal canal. So referring back all the time to the patient's personal experience and the physical exam you found. Shall I go through the 5 scenarios, or is it okay? The fourth one is it's a typical one in my practice, and here I really have to emphasize that this is about musculoskeletal problems, because here the evidence says that the changes in disc, so the bulging of the disc or the degeneration of the disc, is really age related. So the older we get, more of these changes we have in the spine, and they not necessarily cause any symptoms. So there is not a good relationship between the MRI findings and the imaging and what symptoms the patient has, or if they have symptoms at all. But it's a regular or common experience that they are very much afraid. So if there is a bulging shown on the MRI, then patient starts to freak out that, oh my God, this will lead to herniation, and my neighbor had that, and he ended up in wheelchair. Okay, I'm catastrophizing now, but to make the point. And they have no symptoms at all. Their movements are free, they don't have any pain anymore. Then the main thing is to address this concern and maybe talk about the evidence to show them that they can load their spine. We just did the examination, you did bending forwards, nothing happened, no pain was provoked. So this is again a very different information provision and education of the patient, and maybe treatment strategy also. And I think the 5th one is my last one. With the low back pain, where the patient, for example, has an ill mother, father, family member, whoever, who they have to take care of. And if you have to take care of a seriously ill person, then you can't really avoid bending above the bed to help them sit up, turn, feed them, whatever. And if you have a kind of a back pain that in which case temporarily it would be beneficial to avoid bending, obviously that will contradict the life situation of the patient. So here you have to discuss the possibilities, what the patient feels capable of doing or not doing, how much time or energy they can devote to this therapy, which is more important. And there, I think the shared decision making is the most important point here with the therapy process. So this is all connected. Being curious, exploring all these factors, understanding them, but also connecting it to all the clinical factors and that could influence outcome. I think the summary, basically, I already told once or twice on the next slide. So it's important that the patient feels that we are not just treating a general idea of a problem, but we are treating and caring for them. And we are also aiming to address what matters to them, as Lode said at the beginning. So all the content of our education and treatment strategy has to address these problems. And what I also mentioned, the next slide we already talked about, so the emotional part, I mentioned in advance. So we can skip that and just get to the next slide, which I also mentioned briefly. So all these factors, what we call these drivers of pain and disability, that we have to explore. Not every patient will have necessarily all these factors, or any of them for the matter, but we have to notice if we do, because they are really can be factors and risk factors leading to chronic pain. So these are the unhelpful beliefs, catastrophizing, pain coping mechanisms, or if they are really too much afraid of pain, meaning harm, or if they are not expecting any good results from the therapy. So basically, I had patients too who said at the beginning, well, I don't think this will work, but I'm here anyway. There you have a harder starting point. And actually this aligns, so all that we talked about aligns with the evidence too. So the guidelines also recommend this exploration of the psychosocial factors. Now it's called, sometimes it's called psychologically informed physiotherapeutic care, which is basically what we talked about. And why this is important, because all this patient-centered care and communication is positively correlated with therapeutic alliance. Lode also talked about this too. And this therapeutical alliance, again, has an influence on how much the patient thinks that the treatment actually works. So the perceived effect of the treatment has also a connection association with the therapeutic alliance. So sometimes maybe not even, sometimes it is more important, these factors regarding the outcome, than the treatment itself. So how much evidence shows that this or that treatment is effective. This does not mean that we shouldn't apply evidence-based treatments, but we have to recognize all these other factors that influence outcome as well and utilize them in the care process of care. And I think that was my part mainly. So Lode has some final important thoughts.
Well, just to conclude, and we saw some questions coming in from about interprofessional communication, interprofessional work, and we specifically talk about interprofessional and not pluri or multi-disciplinary, because there's one thing we and you have to keep in mind. It's all about the balance of powers. We were trained, when we were younger, we were trained with the doctor who was on top. And then you had all the other disciplines. I don't know how it is in your country, but in our country, that really luckily has changed because of the patients. They don't accept that anymore. This powerful doctor who is telling everything, regardless of the person in front of him or her. So the balance of powers has to be equal. We need the expertise of the patient, and we all need the expertise in between this interdisciplinary team. Without the help and knowledge and the expertise of the nurses, of the physiotherapists, of the occupational therapist. And when you look at the picture, when you go to the next slide, you even see the guy who helps the cleaning. Everybody has to do his or her work.
Sorry,
Sorry?
Лоре. Сергію, а можна наступний слайд вперед, а не назад?
Next slide, please. Not that way, seems to me.
З кружечками голубими.
With blue holes, yes. Good.
Exactly. So you can see everybody has to do his or her work. Even when the cleaning team, I used to work at the intensive care of the Department of Heart Surgery. Even when the cleaning team didn't work properly and had their say in how things should be managed, things didn't work for the doctors, nor us, the physios, nor the nurses. So there has to be a balance of powers here. And why is that important? If you go to the next slide, and this is the last one, this is, sorry, again, about this effective communication, because it ensures the fact that we are patient-centered. We need to give the steering wheel to the patient. So as in a car, that the patient can hold the steering wheel and decide whether his or her car goes to the left or the right or straight on. We need to give this steering wheel to the patient, and that's patient-centered. And that's giving a safe environment and coordinated care when you're working in an interdisciplinary team with clear roles, with shared goals and mutual respect and mutual communication. So we have a program, for instance, in Antwerp and in Ghent University, where students from the medical department, physio department, dentistry, social assistant, nurses, they all work during 1 week together. And what we, just to give an example, quite often see is that medical students very rapidly, the first day on Monday, they start taking the role as the leader, but they very quickly learn that they need the help of all the others who are far more experienced in matters they don't understand. And by the end of the week, the main conclusion is that they should work as one team with shared goals and shared communication, and again, a shared power, balance of powers. Everybody is equal. And I think I've covered together with Anna all these slides and these topics. And to end, I want to say that I was, and I think Anna as well, we were very honored to be invited and to be able to present this to you. Thank you very much.
Thank you very much for your experiences and also insights. Is it okay if I ask you a couple more questions while we are waiting for questions in the chat? We have a question from Tatiana Amelina. At what point, like from which year, do physiotherapists learn about patient-oriented approach and communication skills? Maybe you could speak a bit about how the communication skill training is organized in the rehabilitation training program.
If I can talk about Belgium, for the physios, it's the last 3 years. It's a 5-year program, 5-year at the university. The last 3 years, they are really immersed in the biopsychological way of treating people, treating patients with communication training. For the medical students, it's from day one. Medical students and dentistry students, they have all their years training. They also have communication training. For the physios, it's only the 3 last years.
In Hungary, they don't learn, so it's a short answer.
But Lode, is there an explanation why physiotherapists don't learn it from the very beginning?
Yeah, that's that's a good question. That has to do with professors that they are being trained and having the role of being professor, instill this biomedical vision of a patient. And quite often they think the biomedical part is far more important than the psychological part and the biosocial part. So we started, I didn't have to do anything with it, but the university started by giving 1 year, the third year, and gradually minds started changing mainly because medical students are being trained already for more than 30 years, like from the first day on. So when they looked at the curriculum of medical students, most of the professors in physiotherapy started realizing that communication should be more important than and the biopsychological way of looking to the patient. And that's why we have now the last 3 years.
Thank you. We have a couple more questions from the forums. Maybe, yeah. So one of them is we can do it as a short case consultation. The question sounds like, can you please suggest a couple of techniques to start a session with a patient who refuses to talk? That's one question. And the second question, in addition from me, like the patients has to be very aware and responsible individuals to set their own goals. And especially in our environment, it's always problematic, not always, but often, because the patients are used to be told what to do. They are not used to be asked what is their goal. And sometimes they may not have a clear answer to that question. Maybe you also have patients like this, and how do you help them learn to set their own goals and to take the lead in their treatment?
If you want to respond, you can.
I would take the second part, and the first question you could take, if that's fine.
What was the first one? Sorry,
The patient refusing to talk and how to start with that.
what do you think? I don't quite understand what is a patient who doesn't want to talk.
That they don't want or can't.
Yeah, that they are not sharing, they are not giving you open answers in the way you expect them. Maybe we could.
Yeah, I see. And there's a relationship with the second question as well. Yeah. Well, that's providing them a safe environment. And I fully understand. Like, for instance, the example I gave from this young woman who had suffered from child abuse when she was a kid. It started at 8, when she was 8 years old. Of course, she didn't provide me with answers immediately, but she felt that I was genuinely interested in her, in her problem, but also in her life behind the problem, what this problem meant to her. So even though she didn't give me all the answers, the patient has to feel that there is time and there is place and there is safety to start doing that even on a second or later time when we see them. So we shouldn't be digging and pushing patients, because when we start pushing them, they start pushing back, and then we lose them. So that would be my main answer to that question. And the second one is for Anna.
Yeah, that also depends on what your impression about the personality is, but you can start with what we talked about, the work demands, leisure activities, functional limitations. Surely something came up there. So if they don't express a goal of their own, then you can refer back to that. So you mentioned you had to stop running. Did you like running? Would you like to run again? And then is it okay then if we note that down as a goal? So discuss in that way, or even again, depending on the patient, but you can give them that as a homework to think about it. But if they are completely reluctant, then you can just say, okay, we skip that for the moment. If you think about anything, we'll discuss it. Just let me know any point you think about it. So it depends.
Our
There's
experience,
no
yeah,
true one.
our experience is that when you, and think of your own life, everybody present here, when somebody is really interested in you, you automatically, after a bit of time, you start talking and you start answering. I often get a response, how can I, when I start with a very open question, how can I help today? And they say, yeah, you tell me, you're the expert. And then I say, that might be true, but you're the expert in feeling your problem, and I need your expertise, so tell me. I think I can say, it's a difficult word, never, but I almost never get somebody who doesn't start talking then, because I call them an expert in their own life, in their own feelings, and what this back problem, for instance, is doing with them, and they start talking.
Thank you. We have maybe this the question from Lisa, who can deliver this course, psychologist or physical therapist or head of the department, doctor. So maybe you could comment on whether it's just one course, because we actually, in a number of meetings with different colleagues from different parts of the world, we discovered that it's never just one course and that communication skills are usually integrated throughout the program. But maybe you could comment on that for the 3 years that you're working with, and who should be teaching it. Yeah.
If I can answer, Anna, from our perspective in the university. I was teaching at 3 departments, the medical students and dentistry students, and it was always an interdisciplinary team. My colleagues were, I was the only physiotherapist, and all my colleagues were GPs, general practitioners, doctors, and psychologists. But that makes that we had this, my last slide, this interdisciplinary way of working was already implemented in the way we were teaching them, because one day this group of students could have motivational interviewing from me, being physical therapist, and the next day they could have the same going further on this motivational interviewing from one of my colleagues, psychologist or a doctor. And in the physical therapy department, we were always in pairs, one physical therapist and one doctor. And the students' physical therapy, they really loved it, because then they could ask questions to the doctor present, how they were thinking about certain biomedical problems, but also about the biopsychological problems. So we were always working in duos. So even at the university level, undergraduate students already were immersed in the fact that most of the time we work in an interdisciplinary way, and that was reflected by the people teaching them.
Anna, how is it done in your training program? I mean,
Well, we
we
don't really
already
have
heard that
one.
it's not formally taught, but in the training program that you completed outside of the formal university.
Yeah, but that was each courses, so that was not Hungary, not in Hungary, not in Hungary in Hungarian. So I was going abroad to learn about this all,
Okay.
unfortunately. But it's getting better here as well, but not at the university undergraduate level.
Mm-hmm. Great,
So
thank you
that's
so
still
much.
missing.
All right, so maybe I will just, we will wrap up and I will do a short summary and then we call it a day for today. It's about the time to finish. So For me, I will just maybe not everything, but highlighting the key things that I learned today. For me, the key word of the day was curiosity, and I think the key message is that curiosity is the one that creates genuine interest, and genuine interest is what helps understanding, and then everything else comes naturally. So for me, it was also like a really important focus that we don't just teach people how to talk or how to listen, but we actually encourage them to be genuinely curious, because once that is there, then everything else comes. And I think that is like the core message, and it really resonates with me. And Anna started with the Glasgow statement, consensus statement. And maybe the first kind of key message was connect as a human. And I think the major part of your presentations today, at least for me, and please correct me if I'm wrong, you kind of spoke about your relationships as teachers and also as therapists to students and patients. And I think I heard that you practice the same approach to both students and your patients, and that's what helps you to teach it. And you mentioned a number of times that you need to connect to students as to humans and also to patients. The curiosity part, that you have to be curious, and both with students and with patients, and building relationship both with students and patients. And then the core is to provide safety and time. And you also mentioned this in the context of working with patients and working with students, that you need to provide safety and time in both contexts. And then we went a bit more into the nitty gritty of communication, and Anne gave a number of examples about how different points of pain can mean different things, and we can only learn about them when we are curious. And here the key is that the communication is defined by the goals and expectations of the patient, not something else, and that's why we also need to take time to explore them. And the key message, I think, is like treating an idea of a problem versus caring about the person is also a very at the core of this curiosity, is that in order to care about the person, we need to learn about him and not just use our assumptions about the diagnosis and the discomfort that comes with it. And it's a concrete experience that matter and the concrete person. So yes, curiosity creates genuine interest creates understanding, and everything else follows. I guess that would be my key message from today. Okay, I see that Anna and Lode are nodding. So okay, thank you so much for today. I want to invite our guests to follow our next event. We plan at least two for the spring. One about the different role plays that we could use um, in the room when we teach communication and empathy, and how we could adjust and choose these role plays. And then another one is from Peter Pipe that some of you may have heard Peter before. We will talk about managing organizational change in the context of introducing new courses or innovations in your teaching, and how to do that in a smart way and overcome resistance and build partnerships on the way. So we will keep you posted through emails. Я перейду на українську. Да, ми надішлемо вам
Yes, and now
презентацію з
I will
дозволу
switch
Лоди
to
на
Ukrainian.
англійській.
So if
Використовуємо
Anna and Lore don't mind, we will send out their presentations to you, to those of you who are registered participants, and we will keep you updated about the following events that we will have. And let me wish you good luck in everything. Stay with electricity, stay with good energy. I see that some of you are staying without any electricity now, but thank you for coming. Thank you for joining us, and take care. Stay safe, and thank you again for today's call. Thank you.